back me up on it. I'm going to make 6 points to this board. Hopefully you'll bear with me. I'll take no more than 10 minutes to make those points. And I suppose the introduction is really the East Midlands Congenital Heart Centre, based at the Glenfield, has made excellent progress over the last few years through the leadership of our clinicians. We've expanded the bed numbers, improved our outcomes, invested in staffing, created a new adolescent unit, and have recently briefed architects to create a new single-site children's hospital, which will both meet NHS England's co-location standards and provide a wonderful new environment for all the children that we care for. This has obviously been achieved against a backdrop of many years of uncertainty, following what the Secretary of State described as a flawed decision to stop surgery in Leicester 4 years ago. And if truth be known, it does make us wonder what this service could have achieved if it had NHS England's backing. It will come as no surprise when we say that we cannot agree that NHS England's decision to cease commissioning children's heart surgery in the East Midlands is, as they state, in the best interests of patients with congenital heart disease and their families. We fail to see how leaving the East Midlands as the only region nationally without a centre is equitable. And if you allow me the next few minutes, I'll set out our case with those 6 quick points. Point number 1, we already provide a high-quality service. Our most recent clinical outcomes, when compared with current published data, place us alongside the best-performing surgical centres in England. And we confidently predict that upon publication of the most recent data in October 2016, that the clinical outcomes for our patients will again be amongst the best in the country. And this is despite seeing more patients than we've ever seen before, and recognising there have been no deaths in the centre 30 days post-surgery for over 15 months now. Recognising, as NHS England say, that quality is about more than outcomes, our same-day cancellation rates, our unplanned reoperation rates are significantly better than the national average, and in terms of patient experience, our patient friends and family test runs at 99%. All of this is supported by the Care Quality Commission, who members of the audience will probably know were in at UHL just a few weeks ago, and their feedback following their inspection cited the excellent clinical outcomes for children following cardiac surgery at Glenfield Hospital. So our first rebuttal to NHS England's assessment of our service is that they therefore want to close a centre beloved of its patients and families, despite quality and mortality indicators that ought to alert them to the fact that this is a grave mistake. The second point I want to make is around the numbers, and the fact that we are on target to meet the numbers of surgical procedures. And if you let me explain. In 2014-15, we carried out 280 surgical cases. In 2015-16, we increased this to 332 surgical cases. Based on current projections of activity, we expect to meet the standard of an average of 375 cases per year with 3 surgeons over the next 3 years. And it's worth bearing in mind, to accommodate this additional work this year, we expanded our bed base by a third, including the provision of the adolescent unit and a short stay bay at a cost of just under £1 million. However, we now note that the standards that we were consulted upon changed at some point after the clinical engagement exercise, from a commitment to achieve 3 surgeons and 375 operations from the introduction of the standards in April 2016, to a retrospective 3 surgeons and 375 operations by April 2016. In effect, NHS England have shortened the timescale for us to deliver that by 3 years, which they must have known automatically excluded Leicester from the outset, and yet still took a paper to the NHS England National Board which said major reconfiguration of specialist services with associated risk and upheaval can probably be avoided. All that aside, I would remind colleagues again that the evidence for 125 cases being the magic number is, in NHS England's own words, arbitrary. The people tasked with researching this, the School for Health and Related Research in Sheffield, found that, whilst a relationship between volume and outcome exists, this is unlikely to be a simple, independent and directly causal relationship. In other words, no cut-off to surgical volume and better outcomes was identified. Which is why the author of the report, which NHS England have used to substantiate the 125 figure, said last week that she had no idea how NHS England arrived at the 125 figure. She went on to say, "I certainly can't recall that I ever said that there was a minimum or maximum number of cases which should be done each year by an individual surgeon." So our second point of rebuttal is that NHS England is therefore proposing to close a top quality service, despite the fact that clinicians working in the service are confident of their ability to perform the required number of procedures. This is compounded by the fact that the standard has now been applied retrospectively, and the very premise for the decision is based on an arbitrary number of cases for which NHS England's own reviewer has said there is no scientific evidence. We would therefore encourage our colleagues in NHS England to look instead at our outcomes, our zero mortality, and our actual results. Third point, this is around a compromised paediatric intensive care service. I'm going to use the acronym from now on of PICU, but it basically means Kids Intensive Care. So the Congenital Heart Centre supports 12 PICU beds at the Glenfield Hospital, which will obviously be lost if NHS England cease to commission surgical services. Of equal importance, however, is that as a consequence of losing these beds, the viability of the PICU at the Leicester Royal Infirmary will be severely compromised. As colleagues will be aware, paediatric intensivists in Leicester work across both units and, in common with other units, are attracted to Leicester by the diverse caseload that this offers. The loss of a specialist PICU at the Glenfield, which, by the way, more than halves the total PICU beds in Leicester, will mean that children's intensive care will cease to be an attractive place for our clinical teams to work, meaning we will lose existing staff and find it harder to attract new staff. Now, taken together, the two Leicester units provide 30% of the PICU capacity across Birmingham, Leicester and Nottingham. Close one, destabilise the other, and even assuming a bed can be found somewhere in the region, more children and their families will have to travel further to support one another in a time of crisis. Which we think is why the recent National Paediatric Intensive Care Directors meeting, this is as recent as 11th of July this year, released a statement, having heard about NHS England's decision around Leicester, saying there was a unanimous opinion expressed that the NHS England proposal makes proper evaluation and response impossible and presents a significant destabilising pressure on PIC services, which may be further destabilised through the proposed PIC national review. So our third rebuttal is simply that given the national crisis in paediatric intensive care capacity, the decision to remove beds from the system and destabilise the remaining Leicester PICU seems at best misguided and at worst reckless. Fourth point I wanted to make is what we call the domino effect. So if NHS close our centre, the intensive care unit at Glenfield is lost and the Royals is compromised. And without a sustainable children's intensive care service, there will be an inevitable domino effect on other specialist paediatric services which require intensive care capacity to function safely. These include children's general surgery, ear, nose and throat surgery, metabolic medicine, fetal and respiratory medicine for long-term ventilated children, children's cancer, and finally neonatal units. In addition to the impact just on our trust, those district general hospitals that rely on Leicester for their more complex patients as their nearest specialist trust, these include Burton, Coventry and Kettering, Northampton and Peterborough, will no longer have us as a backstop for their specialist care. So our fourth rebuttal is that if NHS England close the Children's Heart Service in Leicester, they should be aware that they are essentially undermining the vast majority of our other specialist services, not only for the children in Leicester, but across the wider East Midlands. Our fifth point that we'd like to make is around ECMO, extracorporeal membrane oxygenation, or in layman's terms, total life support. So Leicester's paediatric respiratory ECMO service is the largest in the country, and it accounts for 50% of all capacity nationally. And as NHS England are aware, Leicester pioneered ECMO in the UK, and as a consequence there are many children and adults alive today who have our clinicians to thank for a second chance of life, not least those who we saved during the swine flu pandemic in 2010. The Glenfield ECMO is the only unit providing a national transport service which stabilises patients at their local hospital before transporting them to a specialist centre. Obviously, the decision to close Leicester Surgical Service would also result in the closure of the ECMO service, as the doctors who work in one also work in the other. And that means that decades of experience and knowledge and innovation will be lost. So our fifth rebuttal, therefore, is that when assessing our surgical service, NHS England stressed the importance of achieving a certain volume of patients, and it therefore strikes us as odd or peculiar or just convenient that this same volume principle does not apply when considering this country's most successful and highest volume provider of ECMO. My sixth and final point before a brief summary, Chair, is around peculiar and historical patient flows. So we would maintain that if NHS England were genuinely seeking to support centres, we would expect that they would broker conversations that made patients treated in their nearest specialist hospital, and in doing so put an end to the ridiculous state of affairs where, for example, patients in Northampton are referred to a centre in Southampton for no better reason than it was ever thus. If active commissioning of this kind took place, then the 375 or the 500 cases standards will be simple. And whenever we've tried to engage NHS England previously, they have cited that patient choice is the main reason why these perverse flows of patients maintain. Now, let's be clear, it's not patient choice, we all know that. Any parent faced with a sick child will take them to the ends of the earth and certainly to wherever their referring doctor suggests. And so if the doctor referring them for reasons best known to themselves says Southampton, that parent's going to take it on trust. That's not patient choice, that's clinician choice, and there's a big difference. Moreover, on the subject of patient choice, if patient choice is really so important, why are NHS England so insistent on forever removing that choice for the 332 patients and families who consider Leicester as their local centre today? So our sixth and final point is simply that even if NHS England are going to stick with this arbitrary 125 cases figure, they should act as genuine commissioners and make the standard that patients are treated in their local centre, not one in hundreds of miles away. Taking those 6 points together, colleagues, you'll hopefully understand why we were frankly incensed by the fact that NHS England said in their press statement that we will be working closely with Bristol and other centres to support their plans to meet these standards in full, on the same day that we received a letter saying that our service will close. We need to remind ourselves of the history here. In the 1990s, it emerged that mortality in Bristol's Children's Heart Unit was causing concern. An investigation was launched, and it found that 35 children had died as a result of poor clinical practice, with many more having poorer outcomes than were expected. Fast forward to 2014, and there's another review in Bristol, again related to mortality, and again triggered by parents raising concerns. As I said, on the day that the second review published its findings, we received a letter saying that NHS England were minded to close Glenfield. Now, I've lost count of the number of people who've asked me to explain the logic of this. These are intelligent, well-informed people who simply don't understand why NHS England will respond to quality concerns elsewhere by closing a centre with no similar concerns hundreds of miles away, i.e. Glenfield. And to be honest, our clinicians, our nurses, our doctors, our board can't make sense of it either, but we will give you our best guess. And our best guess is actually Bristol cast a long shadow on the profession. The first inquiry was 2 decades ago, and there are perhaps some people in and around NHS England who think that nothing has happened since. But the reality is that everything has changed. There are 5 fewer centres. Quality and mortality data for every centre is published annually. And most importantly, the mortality data shows that in every centre, including Bristol, the mortality rates are good. And by good, I mean as good, if not better, than peers in other developed health economies elsewhere in the world. So mortality has halved in the last 10 years for this surgery. And as such, the only possible explanation that we can offer you is that we wonder if NHS England are now suggesting an old solution which is in search of a problem that no longer exists. So, finally, we recognise that our colleagues in NHS England will find our position uncomfortable and unwelcome. And if I'm completely honest, and speaking on behalf of my colleagues in the service, we're pretty tired of fighting and just want to do what's best for our patients and the families we serve. But I must caution colleagues in NHS England and around this table and anyone else who's listening that if we thought that our teams were being parochial, if we thought for a second that our nurse, doctor and surgeon colleagues were motivated by a desire just to maintain the status quo for their own convenience, I wouldn't be speaking to you now, and our board wouldn't be asking us to pursue the mandate that they have. They're not, probably being parochial, and as such, we cannot, in all conscience, sit by whilst a fabulous service is destroyed. So thank you for taking the time to hear me out.